Good morning. We're going to get started. It's 10 o'clock. Pam, can you move to the next slide? So, good morning, and thank you for joining the New England Nursing Home Quality Care Collaborative. My name is Sarah Drenick. I'll be monitoring today's webinar. Before we get started, I'm going to review a few housekeeping items. This webinar will be recorded, and the presentation will be available within a few business days. I'll provide you with details on accessing both at the end of this webinar. The phone lines will be on mute for the duration of the presentation. We ask that you please do not put your line on hold during the webinar. We will have a few polling questions throughout the presentation. We encourage you to be ready to respond to each question. If you have a question at any point throughout the presentation, please enter it in the chat panel to your right of your screen. We will be monitoring and responding to questions and comments in chat, as well as spend time for questions at the end of the presentation. We will also have time for Q&A during part 2 of this webinar on Thursday, April 28th. Lastly, if you find that the presentation is a little cut off, please use the plus or minus icons in the top right of the presentation window to adjust accordingly. Next slide, please. As a reminder, your state's QIO team is supporting members of the New England Nursing Home Quality Care Collaborative in several ways, as you can see here on this list. As you work on quality improvement, don't forget to check our website for useful tools and resources, learn about upcoming webinars, or access online learning modules. Also, as a participant of the collaborative, your state QIO team is available to provide additional technical support, so please reach out to your state lead. We are here as your resource. Next slide, please. Now, please help us help you. We have a few polling questions that will help us better assess our approaches to serving you. For over 1 year now, we've been creating narrated educational presentations, gathered materials and resources, and placed them on our website for your use when you need it. So our first polling question is, have you visited the nursing home section of the New England QIN-QIO website? Start the polling, please. Please remember that our website is www.healthcarefornewengland.org. And don't forget, once you've selected your answer to the poll, hit the submit button at the bottom. It's going to take a couple minutes to go through, a few more seconds. Pam, do you want to move to the next slide while we're waiting for the results? All right, it looks like the results are calculating while we wait for the results. As I mentioned earlier, we have an array of helpful tools, resources, and online educational modules on our website. And as you can see from the list here on this slide, we have tools and resources on a variety of topics. This is also where you'll be able to access the tools that Pam will be discussing during this webinar. And looking at the results, it looks like many of you have been on our website. So if you have any troubles accessing anything on these topics or accessing the tools that Pam's going to be discussing, please feel free to reach out to your state task lead, and they can help you access those materials as well. Next slide, please. So our next polling question, as we're creating new presentations and gathering resources, we want to understand which topics are most important to you. So as we prepare for upcoming webinars and making the information available for our website, which 2 topics are of greatest interest to your nursing home? Please begin the polling. And don't forget, as you're selecting your top 2 choices, hit the submit button at the bottom. While we're waiting for everyone to make their selections, Pam, do you want to go to the next slide? All right, so it looks like everyone has made their selections and we're waiting for the results to tabulate. Again, I encourage you to go on our website and check out the materials we already have available. Many of you, it looks, we'll find out what you're interested in seeing in just a few seconds. But thank you so much for providing this feedback and helping us shape future webinars, calls, and educational materials. It looks like the top topics to look at moving forward include incontinence, help with ADLs, staff stability and turnover, and also QAPI tools. So keep a lookout for additional resources and education on those topics moving forward. Next slide, please. Now let's move on to today's program. The objectives for this session include understanding the pain quality measures and how a resident triggers for these QMs. You will learn about the key points for pain management, including screening, assessment, and measurement. We will be discussing communication and documentation, and you will learn more about non-pharmacological interventions. Next slide, please. I'm happy to introduce Pam Heckman, who will talk about best practices for pain management. Pam leads the nursing home work for the New England QIN-QIO in New Hampshire. She has 15 years of experience in quality improvement in long-term care and 17 years of experience in home health care. Pam is a registered nurse in the states of Maine, New Hampshire, and Vermont, and holds a Bachelor of Science degree in nursing. Welcome, Pam, and I'm going to turn things over to you now.
Thank you, Sarah. I hope everybody can hear me all right. I'm going to get started. And today we're talking about the two quality measures on pain. The first one is the self-reported moderate to severe pain for short stay and the self-reported moderate to severe long stay. SR, which is in the front of the measure on your CASPER report, refers to self-report. And short stay is defined as an episode with cumulative days in the facility at less than or equal to 100 days as of the end of the target period. And note also that the percentile ranking is now a national ranking, not a state ranking. This slide shows the facility-level CASPER report, the sample, and it lists the denominators for the 17 quality measures. Note that some of the denominators are different from others. They vary due to the exclusions. An exclusion can take a resident completely out of a measure. In this example, you see 20 in the denominator for long stay pain and 26 in the denominator for long stay restraint. I usually use the denominator for restraint to identify the base number of long-term residents who had an NBS assessment in this time frame. So to me, 26 minus 20 indicates that 6 long-stay residents were unable to self-report pain. The current data that we have, based on the most recent CASPER report, which I pulled for the rolling quarter January through March of 2016, shows that the comparison national group average is for long-stay pain is at 8.2%. The comparison group national average for short-stay pain is 16.9%. You can find your state's average for short and long-stay pain on your current CASPER report, the facility-level report. There's quite a few questions in the MBS on pain, but here are the relevant ones, the ones that affect your quality measure report. JO200, should the pain assessment interview be conducted? This question is very subjective. What staff, for example, do you assign for conducting the interview, and how do they decide whether the resident is capable of answering the questions or being understood? It's not very clearly defined in the RAI manual. If the resident is coded as a yes, then that resident will be in the denominator of the quality measure for pain. So who triggers for pain? There's several different ways. This slide identifies that the resident could self-report pain, experienced pain almost constantly or frequently in the 5-day look-back, and used the numeric scale 0 to 10, reporting the worst pain at a level 5 or higher at least one time. This slide is not a duplicate. It identifies the resident could self-report pain, experienced pain almost constantly or frequently over the past 5 days, and used the verbal descriptor scale, reporting moderate or severe pain at least one time. JO400 is the pain frequency question. In this case, we have to ask the resident, using the exact words, how much of the time have you experienced pain or hurting over the last 5 days? The options are listed there. And note that there's no predetermined definitions offered to the resident related to the frequency of pain. The response should be based on the resident's interpretation of the frequency options. The facility policy should provide standardized tools to use throughout the facility in assessing pain to ensure consistency in interpretation and documentation of the resident's pain. That paragraph is directly from the RAI manual. The questions JO400 and JO600 will determine if the resident will trigger for pain, as long as they're in the denominator. Here we have JO600A and B, and the directions are to administer only one of the following pain intensity questions. Either use the numeric scale or the verbal descriptor scale. The resident needs to rate the intensity of their pain at 5 or higher, or rate it moderate or severe at least one time in the 5-day look-back in order to trigger for pain. I don't know if you have any questions so far. Please go ahead as we go along and enter your questions in chat. I'm not going to stop to answer them now, but we will be answering them either at the end of today's session and or next session on April 28th. Your questions are really important to me, so please don't hesitate to enter them in chat. I made this chart to show that the matching of number and word, for example, 1 through 4 is considered mild pain. This is taken directly from the Quality Measures User's Manual, which is available from CMS. So it's very important to recognize that these numbers match the words. Again, 5 to 9 is moderate pain, and 10 is the very severe or horrible pain. This picture is the back side of a 2-sided pain screen card that the New England QIN-QIO has available for you. The other side, which I'll show you in a few minutes, has descriptors of the numbers and the pain add tool. This side has the descriptors of the various pain levels, and these are really quite accurate. Just on a personal note, I experienced the pain of a kidney stone at one point and took myself to the ER and declared that my pain was a 9. I needed help right away. But when I read this card later on back at the office, I realized my pain had really only been an 8. So this really works. It's good for alert and oriented residents. It's good for your skilled residents, for their family members, and it helps folks to understand the pain scale of 0 to 10. I'll show you the other side in a couple of minutes, and I do encourage homes to use this tool for education of residents' families, or even for your liaison who might be going to screen potential skilled patients at the hospital. You can use this as a tool to show them that you really are serious about maintaining them as free of pain as possible, and you can get them started on how to use it. So this is the third way that a resident could trigger for pain. If someone has, for example, a migraine headache, their pain could be self-described as very severe, horrible, or a 10 out of 10 on the numeric scale. In this case, even if they only experienced this pain one time in the 5-day look-back, they would also trigger the quality measure for pain. The exclusions for the two pain quality measures, both short stay and long stay, include the following. It's not limited to this, but these are key. If the resident did not complete the pain assessment, if JO200 is scored 0, they will not be in the measure. This is an exclusion, as I mentioned before. If the resident is unable to answer the pain present in the last 5 days, JO300, then they also will not be included in the measure. And if the resident was unable to answer pain frequency in the past 5 days, JO400 equals 9 on the MDS assessment, they would be excluded. So essentially, this indicates that your numerator is all of your residents who are able to complete the self-report pain assessment interview and have pain at a certain level. And the denominator here is all of your residents who are able to complete the pain assessment interview. So that's why you'll sometimes see that denominator smaller than the total denominator for the population. Again, who in your facility completes the MDS assessment portion related to pain? Do you have any nurse on your unit doing it? Do you have just the MDS coordinator? And are these folks that are doing that portion trained and consistently using the same approach? Have you audited to see that the process is consistent and appropriate? Do your unit managers sometimes do an observation to make sure that the same approach is being used? And consider trust a factor for the resident. Does the resident feel comfortable answering the questions to the assessor, and do they trust that their pain medications won't be decreased if they say they have no pain? Again, this goes back to the question JO200, and it was a question answered by Rena Shepard, who's President and CEO of a company, RRS Healthcare Consulting Services. But Rena also answers a lot of questions on the AANAC, the American Association of Nurse Assessing Coordinators, in their Long-Term Care Daily Digest, which I highly recommend. I read it every day. And she wrote that the residents should be observed in the days leading up to the day the interview will get attempted. And if the resident is rarely or never understood in that time period, then the interview should not be attempted. But if the resident was understood at least some of the time, then the interview must be attempted. If the resident is not able to answer the question, or if some answers are nonsensical, follow the instructions for each of the interviews to determine if and when the interview should be stopped and the staff assessment completed instead. And she notes that the scripts presented in the manual must be used when conducting the interviews. From the AMDA Clinical Practice Guideline for Pain Management is this definition, which I like. It's an individual's unpleasant sensory or emotional experience. Using the phrase best practice in nursing has become increasingly popular over the last few years, but at the same time, a clear and consistently used definition of what best practice really constitutes remains unavailable to many practicing nurses. The goal of best practices is to apply the most recent, relevant, and helpful nursing interventions based on research into your real-life practice. Let me take just a minute to talk about a tool that we have posted on our website recently, and it's a pain checklist for nursing homes. And we're sharing this with those of you who registered for today's call. It's a useful tool to assess for any gaps you may have in your system for delivering optimal pain management. We recently revised it. It's something that we've been using over the last several years at the QIO, and I think you'll find it helpful if you're looking at your system of care around pain management to see where the gaps might be. I'm now going to go through the steps of best practice in pain management. Assessment is a comprehensive assessment tool, and the frequency of it is used on admission, quarterly with MDS, or with changing condition or onset of a new pain. So does your policy or procedure indicate the frequency and situation when a comprehensive assessment is to be done? And then do you randomly monitor to be sure that the comprehensive assessment tool is used appropriately, completed thoroughly, and followed up on as needed? I ask that your definitions in your assessment tool match the MDS. I think it's important to go through your assessment tools and update them if there's a discrepancy. Does your assessment tool use a 0 to 10 scale, for example? I know years ago some nursing homes were using a 0 to 15 scale. And then indicate frequency by words used on the MDS assessment. Do the words match? Screening for pain can be done by various levels of staff, including your LNA or CNA, your LPNs, your RNs. But assessment for pain can only be done by licensed nurse or other professional who is eligible by their license to do patient assessment. And I asked here, too, about a tool that we call the PainAd tool, or whatever tool you're using that's a validated pain screen tool for residents with dementia. Are the staff trained how to use that tool? A variety of staff can do a pain screening, but they should all be consistently using the same screening tool for residents from screen to screen, and also consistently use the same approach and know how to use it. We recommend the PainAd tool as a validated tool, and there are definitions and instructions that come with it, and it is posted on our website. But some of you may have other tools that you're using for your residents with dementia. And we'd welcome you to post what tools you might be using in chat so that you can share what seems to be working for you. Meeting the comfort goal of a resident. You're measuring the success of your intervention. And in doing so, you really need to have a baseline for where your resident is and a goal for where you're going to see if you were successful. Did you meet the resident's goal? So knowing their comfort level or their goal for pain relief is important, and you can collect it on your initial pain assessment or at the time that they're admitted to your building. At the time that people were using a paper medical record for their MAR, I used to encourage nursing homes to put the comfort level right there on the MAR so that the staff could see it, and if they were administering a PRN pain med, they would know what the comfort goal was, be able to refer to it. But comfort goals can change over time, so keep in communication with your resident. And it's very important to compare the post-medication pain screen number with the comfort level goal to know whether you met that goal. And I also talk about screening being only a moment in time. It's become pretty much a given that every nursing home now does at least a daily screen for pain with every resident. And it should get recorded in the record, such as on your MAR. It can be done even every shift. Some nursing homes do it every shift. But remember that at the time that the screening is done, it's just that moment in time. It's not a snapshot of the entire shift. Screening is done routinely to ask all the residents whether they have pain or not. And the results provide clinically important information about who reports the pain versus who does not report pain and whether their plan of care is working. And of course, the results of reporting pain must generate action to reduce pain. Screening involves specifically evaluating the resident at some point to be sure that no resident falls through the cracks. For example, the elderly woman in the end room on your unit who never verbalizes any complaints won't use the call bell. You need to go and ask her, are you having pain? Have you experienced discomfort? No one in your facility should go with pain without it being addressed timely. And I know the nursing homes are really, really good about doing that. This is a sample graphic of what could be used in your MAR, for those of you that are still using a paper record, so that your regular staff, if the regular staff are not on duty, the person who is doing the screening knows what tool to use for that resident and what their comfort goal is. If the person needs to have a pain ad tool used and someone comes on duty and doesn't know that resident very well and tries to use the numeric score, you're not going to be consistent in your approach. If you have electronic records, how do your staff obtain this information? That's something to think about. When you screen a cognitively impaired, nonverbal resident for pain, and you're using a tool such as the pain ad tool, you need to observe them during movement. And this is written up even on the pain ad definition. Using one tool consistently for a resident, unless their condition or cognitive abilities change, sort of a subjective part of this. We need to know which tool is the appropriate one to use for our residents. Now, this is side one of the New England QIN-QIO pain screening tool. And I know a lot of you probably recognize this tool because we were distributing it throughout the 9th and 10th scopes of work from the old QIO. It has been revised. If you might notice that the faces have been taken off of this tool. And the reason is that I found out that the Long-Baker faces are now owned and proprietary, and you have to pay to use them. So we eliminated them from the screen tool. But I also felt that sometimes that they were being used inappropriately. So that's sort of an individual thing for each nursing home to consider. This shows you the pain ad tool on the right-hand side. And in the website that we have, there's a tool, a pain ad tool, with actual descriptors. So, for example, it describes what chain-stoked respirations are like, what to expect, so that people who don't know the tool can become familiar with how to use it. Do you have other tools that you're using that may be working? Please go ahead and mention them in our chat. So in your facility policy, you probably have identified a minimum required frequency for screening. And it should be done for all residents, not just those that are known to have pain. I'd like to mention that the documentation of results for screening versus your overall documentation of pain should maybe be looked at from time to time. Do you ever see a disconnect? For example, do you see all zeros for screening, but then PRN pain levels are written in at level 7, for example? In that case, you might want to investigate what your screening process is and how it's being used. Pain management requires a team approach. All staff need to be aware of what to look for that may indicate that they're having pain. And another thing to think about is, do you know that your residents are getting good pain relief from their scheduled pain medication in general? Or are we waiting until they have breakthrough pain to discover that? Consistent assignment is something that the QIO is also pursuing and encouraging all of our nursing homes to adopt. Many of you have already, but its known benefits of consistent assignment really help the staff to notice small changes more quickly, and the residents build a trust in their caregivers, and that improves their relationship and reporting. These are some of the known expressions about pain. Pain being subjective. Only the resident knows what level of pain he or she is experiencing. And Margot McCaffrey has said, pain is what the resident says it is, the gold standard in pain management. We need to find out to put a number on pain so that we can measure to see if it's improving. And we need to think, too, about any personal biases we may have. You know, some people can look fine and be experiencing level 8 pain. Here's where I talk a little bit about critical thinking. If your resident's having frequent breakthrough pain, this should be sending a message to you that their scheduled pain medication may not be adequate. And really, then their care plan that you wrote for them, their pain care plan, is failing them. Generally, if a resident has breakthrough pain about twice a day for 2 days, for example, then you should really more thoroughly assess your resident and review the care plan and orders. They may not be getting adequate relief. You can talk to the provider. You can also address non-pharmacological interventions that may help. And have your nurses look for patterns. Maybe the resident has breakthrough pain every night around 3 or 4 in the morning. And lastly, it's important that all of the staff, the nurses administering pain medications, know the duration of these pain medications, how long-acting they are. Some are 3 or 4, some are 6 hours. An example that I give is MS Contin is written for 8 to 12 hours, to administer every 8 to 12 hours for pain. But I've seen reports where residents start complaining of pain after 8 hours. So in that case, it probably needs to be given more often. But we need to be watching for that and looking at the time that a resident might report breakthrough pain. So the pre and post documentation of pain when you're giving a PRN pain medication is important. And best practice is to use a validated tool to evaluate the resident approximately an hour after medicating them, even if they appear to be sleeping, and compare results with the comfort goal. You want to document your evaluation, including the pain location, the type of pain, the level of pain prior to medicating. And get from the resident the number or the verbal descriptor, or if you're using the pain ad tool, for example, you would also obtain a number from that. And then document the level of pain relief achieved approximately an hour later. But it's important not to document positive results or good relief or sleeping. Now, I've talked about this with some nursing homes. I had an experience one time where a gentleman was apparently sleeping, and I was attending to the nurse who was passing medications. I was shadowing her. And I said, I had seen the report on a certain gentleman who was quite sick and been getting quite a few pain medications. And I said to her, when did you last give him something for pain? And she said, I gave it at noon. And I said, oh, well, it's 1 o'clock. I said, has he gotten relief? And she said, oh, yeah, I just walked by his room. He's sleeping. And I said, well, okay, but let's go and just check on him. So we went to the door, and when he heard my voice at the door, he waved me in. Apparently he was not asleep. And when I got over closer to his bed, he was lying on the bed facing the wall. He whispered to me, it's a 10. And he died a week later. He had very severe cancer. So I've used that as an example that we have to be careful about making assumptions that a resident is asleep. And I think that it's possible to go in and gently touch a resident on the shoulder, perhaps, and just say, are you okay? Did you get the relief you needed? Even if they can't give you a number, but at least they can answer you so that you know that they're okay. You don't need to go in and put the bright lights on and roll them over and ask, are you comfortable? But it is important to do the follow-up check if you're giving them something for pain on a PRN basis. This is a copy of a tool, and it is posted on our website, that identifies a way that you can document the pre- and post-pain scores, descriptor, and intervention. And one of the nice things about this is that it records the administration of medication and the episodes of PRN pain on a chronological basis. And in a couple of scopes of work ago, we promoted this tool to be used so that a nurse, instead of using the backside of any of the MAR pages, would only write PRN pain medication administration on this page, and it was in the MAR books. It made reviewing a resident's administration of PRN pain meds much easier. It's still available for those of you that are interested in it. Let's go on to the next slide. But with an electronic medical record, are you able to go into it and see a one-page snapshot of all the PRN pain meds the resident has had, say, in the past 5 days or 6 days? You want to see if you can make it easier for your nursing staff to see the PRN pain medication usage at a glance. What if the post-PRN pain medication pain screen reflects an outcome higher than the resident's desired goal for pain relief? Does your policy or procedure guide your staff on what to do? Staff may need guidance to know a consistent approach and to know are their decisions consistent with your facility approach to quality care. Here's another question. JO100B in the MDS assessment asked, did the resident receive PRN pain medications? And in this case, the MDS assessor answers yes if the medical record contains documentation that a PRN pain medication was received, or if it was offered but declined. So it's important that even if the resident declines your offer of pain relief, that it gets documented. Once you have a good system in place to manage pain, it's the ongoing monitoring of the aspects of the system that will ensure success. So it involves monitoring and auditing. And the role of delegation from the supervising nurse to the charge nurse to the LNA, all of that delegation requires supervision and observing and monitoring. So keep asking, how do you know that your staff are using the right technique for screening for pain? You need to observe it from time to time. How do you know that the nurse evaluation an hour after PRN pain medication is actually being done? You need to be doing some monitoring, auditing, and evaluation of the record. You need to audit the frequency of PRN pain medications given, and that's something that your charge nurses can be doing, the people that are administering the pain medications should be doing, because again, if it's being given too often over a course of a couple days, then the pain care plan is failing them. And you want to also audit non-pharmacological interventions for pain that are being used and documented. I want to mention SBAR here. Do you use a tool such as SBAR to communicate with providers about pain? I think a lot of the nursing homes are starting to use that tool. It is available on Interact, and I highly recommend using it. You also want to see if your staff are trained in the use of the PayMan tool, and there's a training tool and a training video on that at this website that's listed there. If you're not yet using Interact tools in your center, I would recommend that you go online and look at these communication and evaluation tools. They're becoming an essential part of good quality care. There's also a good auditing tool on the Advancing Excellence Campaign website, which is nhqualitycampaign.org. This tool gives you data and graphs to identify several aspects of your pain management program, including tracking the percent of residents who receive only pharmacological intervention versus those that receive only non-pharmacological intervention for pain. And it also will tell you the percent of residents who receive both types of intervention. You can't forget the side effect of opioids and how important it is to manage for constipation. Start right away. Start it at the same time you might be starting opioids. Important not to wait. So we're going to talk now a little bit about non-pharmacological interventions for managing pain. And again, this is another question on JO 100C. Does the resident receive non-medication intervention for pain? Is there a list of non-pharmacological interventions for pain that work for your specific resident? And can all staff find that list when they need it? And is it added to as time goes by when you discover something else that might work to relieve that person's pain? It's also important to document the outcome of any of these interventions. Otherwise, it looks like you didn't go back and reevaluate. So these are some of the alternative interventions that can be used one at a time, sometimes more than one at a time, but they have been pretty useful in certain situations. I know that when, and I always use a personal example of having had a migraine, the first thing I did was, after taking some medications for it, was to lie down in a dark and quiet room and make sure that I was warm enough and pull a cold compress over my forehead. And about an hour later, if I wasn't feeling better, I would probably get up and do something else, whether I take another medication that was allowed at that time or change the compress or whatever. But what are we doing along those lines for our residents? For example, if one of your residents is having pain, do we ask their neighbor to turn the television down? Do we get the lights out and make it a darker room? Are we offering compresses, massage, and other activities to try to help relieve their pain? For chronic pain, sometimes these interventions will assist the resident. And if you have any interventions or tools that you're using, I hope that you'll share them via chat. We'd like to hear from you what you're using. You can get your physical therapy department involved to help with pain management, which I'm sure that a lot of you are already doing. The TENS unit has been successful in certain cases. And educating your resident on the pain scale before it's needed is helpful. And to give the resident and family the key points that we use this scale to measure our progress, that there's no right or wrong answer. There's copies of the pain screen card that you can download that are available on our website. Avoiding the roller coaster effect, I have a brief story that I went to see a nursing home one day, and there was a gentleman in there who was a truck driver. He'd been there for several months. One day, while he was working, he saw a building on fire and stopped and ran in to save the people in the building. In the process, he suffered severe burns and ended up having a foot amputated and some of his fingers amputated on one hand. When I saw him, he was up in a wheelchair in the hallway, and I asked him how he was doing. He told me, I'm doing pretty well. I've been here several months getting rehabilitation. I do hope to go back to work eventually. He looked at me and he said, the nurses are really good here, but they're very busy and I hate to bother them. I do have pain and I'm on scheduled pain medication. But sometimes the pain gets really bad and I have to call the nurse to get more pain medicine. And by the time she gets here with the medicine, sometimes I'm gripping my side rail really tight and sweating, and I'm in a lot of pain. And then the medication makes it go away for a while. But then it comes back. It's like a roller coaster, he said. Earlier, I'd been told that resident was possibly drug-seeking, and his nurse showed that he had received at least 4 PRN pain meds a day, in addition to around-the-clock pain medication. And I recommended that the scheduled pain medications were really inadequate. There was no evidence to me that he was drug-seeking. And I think that when someone describes their pain like a roller coaster, that's exactly the effect that we're trying to avoid. We know the negative effects of having pain: slow healing, depress the appetite, decrease movement, increase depression, just to name a few. This is where we want to try to keep our residents, at low to no pain. It's our goal. With chronic pain, it's important to remember a lot of times a resident might be having chronic pain due to arthritis or musculoskeletal problems. And unrelieved chronic pain is not an inevitable consequence of aging. When a skilled nursing facility patient comes in, perhaps with a hip replacement, you may be so focused on the current diagnosis you might forget to address their chronic pain issues as well. So don't make an assumption. Does your resident understand how pain medications work, the duration, purpose, and expectations of the medication? I know that we all know pain is what the resident says it is, but we have to ask, is there a misunderstanding or lack of understanding about how to describe pain or what the levels of pain are, how reporting or not reporting pain by the resident will affect their care plan? Many residents may not have any previous experience or familiarity with the concept of a pain scale. On the scale of 0 to 10, a nurse asked some children if 10 was a large number or a small number, and they all said, oh, 10 is a very small number. So then she asked some adults, is 10 a small number or a large number? And the adults said, oh, 10 is a small number. So she started wondering if the 0 to 10 scale, when people are reporting their pain as a 10, was perhaps a little bit off because they thought 10 was still a small number. My own mother had a situation where she was in the hospital and she had been experiencing some pain. I went out to visit her at the hospital and the nurse walked in and said, Ellie, what's your pain on a scale of 0 to 10? And my mother, who was alert and oriented, 91, but still driving a car and entertaining people, cooking meals for 8, playing bridge, very aware of everything, said, oh, well, I think it's about a 6. And the nurse said, a 6? And I said, Mom, your pain is a 6? And she looked at me and she said, oh. I said, well, 0 to 10 is the scale. I said, 6 is pretty severe pain. And she said, well, it's just a little twinge down here. Actually, it's gone now. She said it was probably just gas. So I have to say that example because my mother did not ever have any experience with the 0 to 10 pain scale. She'd never needed to know anything about it. And they didn't educate her at the hospital because she didn't know how to use it. I think that's where we need to go with the nurses, the education of the nurses so that they know to educate the patient. We have to look and see in our facility who's responsible for educating the resident and the family about the pain scale. the staff think someone else is doing it and really no one's doing it? Is education documented when it's done? And is re-education offered? Are family and residents involved in discussing the care plan and medication plan for pain? And does the family or resident feel a lack of control over their pain? Another thing that came to mind when I was writing this was that we need to think about other things that can cause pain that may not always come first to mind. One of the things that I've become aware of over time is that people's bottom hurt from sitting in the chair too long, and this can lead to pressure ulcers. People that sit in a chair for longer than an hour, if you ask them, they may tell you their bottom hurts. Mouth pain from sores, ill-fitting dentures can occur, but do we really check people's mouths often enough? You hurt from pain from diabetic neuropathy. People's hands or back may hurt from arthritis, the chronic arthritis of the elderly. This is so common. Back pain may be occurring from old compression fractures, and leg cramps, claudication, peripheral vascular disease are also things that could cause pain. Pain in the elderly may be recognized by various things such as change in their gait or behavior, resisting certain movements during care, decreased activity levels, or even striking out. And again, this is the benefit of consistent assignment of both nurses on a unit and the aides, because they recognize these subtle changes. Pain in the elderly may also be recognized by restlessness, maybe breathing heavily, deep sighing, or sleeping poorly. And sometimes you'll see people rubbing their legs or their knees or their elbows, groaning or calling out repeatedly. I've been in a situation where I've seen an elderly lady in a room and she kept crying out, "Help me, help me, help me." When I asked the staff about her, they said, "Oh, she always does that." So I encourage you to investigate a little bit further and not think about how, "Oh, she always does that." There may be some reason for her behavior, and there usually is, because all behavior has meaning. On our April 28th webinar, we will have a discussion on pain. We will be having the nursing homes participating on the call to share their experiences and share information with each other. And we will include links to resources and list guidelines such as the AMDA guidelines, and of course have a Q&A session. So I hope you will join us on April 28th. Thank you. I'll turn the call over to Sarah now. Thanks, Sarah.
Thank you, Pam. So, tools or resources discussed today, go to our website, healthcarefornewengland.org, and click on nursing homes. Or you can reach out to your state lead. In addition, the pain assessment checklist, which Pam discussed earlier, is now available on our website as well. This is a series of checklists for you to use to assess processes related to pain management and identify areas for improvement. Next slide, please. We only have a few minutes left, and we've received in chat. We will provide ample time for Q&A during part 2 of this webinar series on April 28th at 11 a.m. Next slide, please. As you work on pain management with your team, be sure to include these as a part of your QAPI program. For additional resources on QAPI, reach out to your state lead or visit our website. In addition, the England QIN-QIO facilitates various affinity groups, including a group that focuses on pain. If you are interested in this affinity group or any other affinity group, please contact your state lead. Next slide, please. Thank you all for joining today's session, and we look forward to hearing from you all during part 2 of this webinar on the 28th. I have just a few last announcements before we end today's webinar. You will receive a follow-up email with a link to a very brief survey about today's webinar. We ask that you please complete it. This is very important. Your feedback can help us improve these sessions and provide you with meaningful programs. Also, within the next few business days, we will send out an email to everyone that contains links to both today's presentation and a recording of this webinar. Don't forget to register for Part 2 of the webinar that takes place on April 28th. Thank you again for attending. Have a great day.